Bismillah ar-Rahman ar-Rahim. Good afternoon. I would like to thank Professor Mohamed Al-Ashhab, Head of Orthopedic Department, Banha University, for the kind invitation to talk about this displaced sacral fractures title, the minimally invasive treatment of those fractures. Sacral fractures are classified by Dennis classification. It's either zone 1. This is zone 1 when the longitudinal fracture line is lateral to the sacral foramine. Zone 2 when it is transforaminal, and zone 3 when it is medial to the sacral foramine. So it's passing through the neural canal. Zone 3 of fractures, which is medial to the sacral foramine and passing into the neural canal, is important because of its consequences, especially the neurological impact, and thus it's subclassified according to the displacement of the usually present transverse fracture line into type 1, which is minimally displaced, only kyphosis, and more kyphosis with more angulation, and completely off-ended, and it could be fragmented but in the same place without enough displacement. Usually there are other fracture lines than the longitudinal fractures, as I said. It could be one of these shapes. And this is another classification for the transforaminal longitudinal fractures of the sacral bone. It depends on the relation of the sacral fracture line to the articulation between L5 and S1, and the integrity of the relation between the pelvis and the spine, or the spinopelvic dissociation, as we talk about, is depending a lot on this classification, which is Isler classification, because the fracture line could be passing completely lateral, or partially medial, or totally medial to the articulation between L5 and S1, and thus affecting the stability between the spine and the pelvis. The problem with the sacral fractures in general, it's a high energy trauma with a lot of degloving of the skin and a lot of hematoma beneath the soft tissues of this area. So there's a lot of problems coming from management of the sacral fractures, coming from the dehiscence of the soft tissue. So we have to put this in consideration. The indications of surgical treatment of sacral fractures in general are expanding retroperitoneal hematoma, because fixation of the fractures then causes tamponade of this expanding retroperitoneal hematoma. And this is very important to save the patient's life, to stop the expansion of the hematoma. When the displacement is more than 1 centimeter, with the soft tissue compromise that I talked about, because the more stability, the more possibility of soft tissue to heal. And another indication of surgical management of sacral fractures, when displacement takes place while you are doing conservative management, that means that it's not uniting. And in the case of neurological compromise, and usually it's in the form of bladder and bowel disturbance, usually incontinence, and it could be also showing L5 or S1 motor weakness. What are the goals of surgery? Stabilization and decompression. Let's talk first about decompression, because it's easier to talk about. It seems that on the long term, direct decompression by decompressing the sacral foramine and the canal, and indirect decompression by just reducing and stabilizing the fracture, on the long term there is no big difference. The real difference is on short term. So my personal bias is that I tend to do direct decompression in incomplete neurological affection to give more chance for complete recovery, and then type 1 and type 3, but I tend to not directly decompress the transforaminal fractures. It seems at least in my hands, that the indirect decompression of the transforaminal sacral fractures is working much better without a lot of hazard to the patient. Stabilization put two important biomechanical factors in mind before doing any attempt of stabilization of fractures around this area. The first one is the lumbosacral pivot point. It's described by McCord in 1992, and it's the axis of flexion and extension around this area. It's this point in the back of L5S1 disc. And for any construct that would stabilize the area around this articulation between L5 and S1, only those devices that pass at least partially ventral to this point would really add to the biomechanical advantage of fixation around this area. And I will talk a bit more about this during my talk. The second concept is the fixation zones. The yellow and the blue areas, zone 1 and zone 3, are the good areas for fixation. But beginning from S2 till the end of the coccyx, this is zone 2, which is not giving enough fixation. The method of fixation that are used are the iliosacral screws. The iliosacral screw is a sacral screw that starts in the part of the ilium which is buttressing the back of the sacrum, then passes in this anatomical void between the sacrum and the ilium. So it passes in two cortices of the ilium, then in this void, and then through the sacrum. To be able to put a screw like this, which is easily transfixing then any longitudinal fracture in this area, you need perfect reduction first. Otherwise, this is a very dangerous screw which can easily pass through the canal. So you need perfect reduction, and you need a lot of image intensification, which might not be very bad for the patient. It's very bad for the surgeon if he's doing this a couple of times every week. He's killing himself. So this is a problem with the iliosacral fixation. The other method is lumbopelvic fixation using iliac screws, and then doing a soud like this, which is fixing the lumbar spine to the ilium. So it's buttressing the sacrum through this method of fixation. There are a lot of methods of fixation that is doing this same function of the lumbopelvic fixation, like this flying buttress method. And you can use both iliac screws and iliosacral screws. It's called MW technique. But the problem is that it restrains all this lumbopelvic fixation. It restrains the waist movement and might cause early spondylosis or adjacent segment degeneration, especially if the lordosis is not well kept, which is the case in most of this lumbopelvic fixation. So we will keep the lumbopelvic fixation to its indication, which is lumbopelvic dissociation. The other traditional method is plating. The problem with plating, it's not minimally invasive. It jeopardizes the skin, which is already jeopardized, as I just said. And if you take the concept of the pivot point, the only screws that work well and pass through the plate is the ones around this area, around the posterior superior iliac spine, and those screws that can pass from the ilium in the direction of iliosacral screws, which is only one or two screws on each side, which is usually biomechanically not enough. The traditional sacral bar didn't work because it's connecting both iliac wings from behind. And it's completely posterior to the pivot point, so it's not working, and it's restraining the movement without real effect on the fracture unit. So I came to this idea in 2010. We started using this internal fixator in my department in Ain Shams University. First of all, we published the first two cases of this idea of the internal fixator. What's in the internal fixator? It's iliac screws on both sides connected with a bar or a rod from behind. So it's like the sacral bar, but the sacral bar, as I said, did not work because it's completely posterior to the pivot point. But if we connect the sacral bar to iliac screws, and the iliac screws are passing from here and through the iliac bone, so by these screws, the whole device is passing at least partially in front of the pivot point by using the iliac screws, and that's why this modification of the sacral bar worked very well. It's very minimally invasive. This is the first case, so we were exposing with a big wound, the posterior sacroiliac spine, but now it's just 1 centimeter that can take 2 screws. The idea is that with the exposure of the posterior sacroiliac spine and directing your screw towards the greater trochanter, you don't need any image intensification. And then, so the 1 or 2 screws on this side, 1 or 2 screws on this side, and then connecting them subcutaneously with a rod. This is one of the cases, and this was the first case. It was an open book fracture with the longitudinal fracture of the sacrum. We used a small plate by fan steel incision first, and then put the internal fixator behind. And then this was the second case when we came up to the idea of having 2 screws on each side, and it caused this very good reduction. This is another displaced case. Actually, this is a life-saving maneuver. It could be done under even local anesthesia. It causes very good fixation to the longitudinal fracture of the sacrum, and with a modification, even with the transverse fractures, as I'm going to talk about in a minute. And it's a definitive method of fixation around this area with very good results. We are using it also for sacroiliac dislocations. The good thing is that we've done a biomechanical study in USA, in the University of Toledo, myself, Lisa Ferrara, and Andrew Wakefield, and Joel from the United States, on 6 fresh frozen cadavers. And we have shown in this result, this experimental study, that it's after creating a longitudinal fracture through the foramine of the sacrum and using this internal fixator, it's even stronger than the intact specimen. And we showed this in the ISASS in San Diego in 2015. And then we had this publication 3 years ago on minimal axis fixation of longitudinal sacral fractures using this novel posterior internal fixator with a minimum 3 years follow-up. It was published in World Neurosurgery, and we have very, very good results according to Pullman clinical score. 84% excellent clinical results, 12% good clinical results, and 4% fair clinical results. Socially, 68% returned back to their work and recreational activities, 20% the same work with less capability, and only 12% had to change their jobs. So in total, we had 66% excellent final results and 18% good final results. The only problem with these implants is the prominence of the screws on the posterior sacroiliac spine, but we can start this medially. And when we do this, we avoid this prominence. And also we can use S2 Ehler iliac screws, which starts a little bit downward and lateral to the first sacral foramen. It starts here in the sacrum, passing in this void in the sacroiliac joint, and then becomes an ordinary iliac screw. We are now using this rather than the ordinary iliac screws, and it solved the prominence problem. We can use it also as a joystick, this kind of screw, as a joystick for reduction of these difficult transverse fractures of the sacrum. Thank you very much.
Thank you so much, Professor Abd Elfatah Saud, for this very interesting talk and very interesting topic. Our next speaker will be my dear Professor Professor Hesham Farhood, Professor of Orthopedic Surgery and the Dean of Al-Azhar Faculty of Medicine, and the role model الأستاذ دكتور هشام فارود رول موديل للأدب والعلم والأخلاق في أساتذة جراحة العظام في مصر. Professor Hesham will speak about cervical and lumbar injuries. Professor Hesham, please, sir.
Rahim. I would like to thank you very much, Professor Mohamed Al-Ashab, the Dean of Faculty of Medicine of Banha University, for your actually commitment, consistency, and all of the good work that you are doing for education of orthopedic surgeons. I hope that you hear me, okay?
Yes, sir, we hear you, sir.
Okay. I would like also to welcome all of the attendees and from everywhere. What I'm going to talk about, it is two case presentation. One of them is cervical injury and one of them is lumbar injury. The first one, is cervical injury. And this is male patient, 32 years old. He had a road traffic accident and he had a road traffic accident since 5 months. He came to me complaining of neck pain with no neurological deficit, and he had no comorbidities. This is the first X-ray that he did 5 months ago, that seen by our colleague, and they just suspected that he might have C1 and C2 injury. So they went for further investigations, which was the CT. And as you can see in CT here, there is fracture odontoid. The 3D was not that helpful because of the cuts and the techniques, so we did not found any help from this 3D. And MRI also, we found some edema at the odontoid back. So this patient was diagnosed already as odontoid back fracture type 2, and he did already X-ray, CT, and MRI. And the surgeons that they saw the patient decided to treat him conservatively. So the patient went for conservative treatment, and they did a follow-up CT scan for him. However, in his CT scan, they found that it is not, there is no that much union at the fracture site. Also, there was something like splitting here, which was oblique fracture in the odontoid base, so it appeared in the axial cuts as well. This is also the more focused CT showing that the fracture is still non-united. And this is the final CT that he did before he coming to see me. He did a CT scan, and as you can see, is non-union here and there, and there. Also, in the sagittal cuts, there is non-union here, there, and there. Okay. So now the question is, this patient is 5 months on the road, and he had the cervical spine injury, he had odontoid back fracture, was treated conservatively. The question, shall we continue on conservative treatment or shall we go for surgical treatment? I discussed the matter with the patient, and the patient asked me about what kind of surgery that you're going to do. I explained to him what kind of surgery, and that we have many kinds of surgery for this, either from the front or from the back. But if we go back again from the front, we found some difficulties because of the oblique fracture and so on. So the back that will do C1, C2, whatever the technique, but it will limit your rotation ability of your cervical spine by nearly 50%. So the patient decided to go for conservative treatment, to continue conservative treatment, even with the possibilities of healing is not that high. So this is a follow-up X-ray showing the odontoid back fracture, but we cannot see if there is healing or not. So we did a CT scan after follow-up. Maybe this is 4 months after he came to see me. And after he started to have this treatment with teriparatide and vitamin D and the calcium. So there is a good improvement and good healing going on. We continued for another 3 months to give him the same medical treatment with Minerva support. And this was his follow-up CT, which found that there is good union. And also we did an MRI, which I don't think that it is an important here, but the patient was anxious to know if there is any healing or not. So we did it for him, and the sound also that there is good healing is going on. Finally, we did a CT 3D, which was not helpful like the other one, but if you look to the bottom here, we found that the odontoid is crossing, the healing is crossing here. So this is united odontoid fracture after conservative treatment. And this is his final CT. And you can see clearly here that there is good, very good union in the odontoid big fracture. This is the axial cuts showing also union, and the take-home message from this case that conservative treatment is a valid option for treatment of minimally displaced odontoid fracture type 2. However, we need to tell your patient that this will take long time. So give him an average at least 1 year to decide that it is united or not. So if the patient willing to continue with your treatment, with conservative treatment, he can take his chances. The second case which I am presenting is about lumbar injury. And this is another patient. He is 32 years old. He had no comorbidities, was given history of RTA since 1 year. So this X-ray on your right side after 1 year from the fracture L1 and the fixation from D11 to L2. This patient complained to me from his back pain. He had weakness of both lower limb. Also, he had incontinence of urine, and he had sexual dysfunction. On examination, he had local tenderness and prominence in the middle of the back, good flexion, but painful limited extension, with grade 3 dorsiflexion of both feet and hyperreflexia of both knees, but no clonus. This is a CT scan showing the nearly united, malunited, compressed old burst fracture of L1, compromising the spinal canal with local kyphosis, maybe up to 40 degrees. This is the coronal and the 3D, and this is the axial cuts, which showing that the screws were put in a proper direction. MRI was done, and also there was like smooth compression rather than sharp compression from the retropulsed fragment. And this is the another shot of the MRI. The axial cuts of MRI also showing the canal, and it's about 50% compromise of the canal. So now we came to the treatment. This patient is a patient for conservative treatment? I don't think so. This patient, this implant will come out of the skin soon, and if we did not interfere now, we will interfere compulsory later on. And in this case will be stage surgery according to the infection and so on. Also, he having a neurological deficit and progressing This is like red flag alarm. This patient need to have surgical intervention. So what's your strategy? Are you going to decompress it direct or indirect? Are you going to do corpectomy? Are you going to do pedicle subtraction osteotomy? Are you going to correct it? How are you going to fix it? How many levels that you are going to use it for fixation? And also, do you go for front surgery, back surgery, or front and back surgery, or you will do it all from the back? Also, are you going to do decompression or indirect decompression is enough for you? So all of these questions need to be addressed and before you plan what you're going to do for your patient. So what I did for this patient is decompression from the back. I did not go from the front. I did only back surgery. We did decompression, especially at L1-2. We widened the decompression that was previously there. And we took the disc out, which was at the base of L1, between L1 and 2. We could not go for the disc above because it is nearly fused. And we put 3 screws on each side, above and below the fracture, and we corrected the situation. And this is what we get post-operative X-ray. This is 1 month follow-up after the correction of this deformity. This patient is doing well, and he is recovering regarding the power in his legs and the reflexes, but his incontinence of urine is still there, so we are still weaning him from his catheter. I did not ask him yet about his sexual function. So the patient is doing better than before, and he is happy. This was the X-ray before, and this is the X-ray afterward. We are following the patient up, and I will keep you informed about the outcome and the result. I'm very happy to hear any question and answer any question. Thank you very much again, Dr. Ashab. And to take message of this case, the implant failure could be avoided by studying your fracture well before fixation, as not every fracture would be treated the same. So types of the fracture are different, and also the method of treatment and fixation are different. Thank you very much.
Thank you so much, my dear Professor Hesham Farhood, for this very interesting talk. And please, if anyone wants to send questions in the question and answer box, I think Professor Hesham will answer it in the question and answer box. Thank you so much, sir.
You're welcome.
Thank you, sir. Our next speaker now will be Professor Mohamed Fawzy Khattab, Professor of Orthopedic Surgery and Spinal Surgery, and the head of the AO Spine chapter in Egypt. Professor Mohamed is one of the eminent stars of spinal surgery in Egypt, and Professor Mohamed will speak about complex odontoid fracture case. Professor Khattab, thank you, sir.
Thank you so much, Professor Al-Ashab, for your kind invitation, and I am happy to be among these eminent stars of orthopedic surgeons all over the world. Dear friends and colleagues from all over the world, I'd like to share with you one complex odontoid fracture case. Before starting this case, I'd like to highlight that odontoid fracture refers to 5 to 15% of all cervical injuries, and it is more frequently anticipated in elderly patients, but in my country, it is usually seen in young populations due to motor vehicle accidents. Anderson and Dolenzo classify the odontoid fracture into 3 types. Type 1, which is avulsion of the tip, and it is usually managed conservatively, and it is only fixed if you have something like occipito-cervical dissociation. Type 2 and Type 3. Type 2 is through the waist. Type 3 is through the body of the C2 vertebral body. It is usually unstable fractures, and type 2 is occur in watershed area, so the incidence of pseudoarthrosis is a little bit high. And type 2 usually amenable for odontoid screw fixation, halo in younger population. In older population, we don't recommend halo because it had a lot of devastating complication. C1 and C2 fusion in certain conditions. Type 3, shallow type 3 can be managed in Philadelphia or can be managed by C1, C2 fusion. The differential diagnosis of odontoid fracture is the os odontodium. And the
دكتور محمد بليز. هو
دكتور محمد.
السلايدز ما بتتغيرش يا فندم، السلايدز ثابته.
طب هي دلوقتي ما اتغيرتش؟
لا حضرتك اعمل فول سكرين يا فندم، هي كده مش فول سكرين يا فندم.
انا عامل فول سكرين.
لا مش معموله فول سكرين يا فندم.
كده
بدات تتغير يا فندم.
يبقى عندي لاج. في لاج.
اوكي بدات كده يا فندم، بس هي مش فول سكرين، بس اوكي ذاتس جود.
انا عندي فول سكرين.
لا هنا مش سلايد شو. دكتور مينا حضرتك معانا في تكنيكال بروبلم ولا حاجه؟
طب
دكتور فوزي تحب اشير من عندي؟
لو عاوز تشير من عندك ما عنديش مشكله.
اوكي ذاتس جود.
اعمل فول سكرين وشير من عندك. ماشي.
حلو.
Sorry for this inconvenience.
انا ما فيش مشاكل خالص يا فندم.
sometimes يعني ساعات كده النت بيبقى عنده
تكنيكال بروبلمز بتحصل كتير يا فندم. هو دكتور مينا هيشير من عنده يا فندم، وسعادتك مشكورا تمام. اوكي فول سكرين دكتور مينا. اتفضل يا فندم، اتفضل يا فندم.
type odontoid fractures, as you said, can be anticipated in younger population. مينا next، ولا انتوا ما شفتوش دي already؟ ابدا من الاول ولا ايه؟ مينا انت سامعني؟
حضرتك وقفت يا فندم.
طيب بس هنا يا مينا ستوب، هنا هنبدا من هنا. The differential diagnosis of fracture odontoid is the presence of os odontodium, and it is usually a smooth, well-corticated piece of bone, and it is usually present above C1, C2 facet, as we can see here in the right lower slide. Next, Mina. Mina, next. And of course, if you have a favorable fracture trajectory, odontoid screw fixation is ideal for the patient because it will not affect C1, C2 motion, and we published simple and easy way to anchor the C2 promontory and apply the screw safely by the use of Yamshiti needle. Next, Mina. And this is our case. This is 23 years old male, presented with axial neck pain, normal motor power, positive Hoffman, positive Papneski, hyperreflexia. So there is signs of cord compression, with history of fracture odontoid fixation 2 months ago, and he is medically free. To describe this X-rays, we can see that the patient has odontoid screw malpositioned. Its tip is usually at the promontory at the lower border of C3, not in the ideal place, and there is dislocation in C1, C2. If we can pick the posterior arch of C1 and the spinolaminar line of cervical spine is not coapted, so it is a complex spine surgery case. Of course, in such cases, we need to do CT and MRI. CT is to diagnose the bony pathology which is present. MRI is to identify the ligamentous and the neurological states, and of course CT angiography is important to identify the state of the vertebral artery as well. Next, Mina. Here in the CT scan we can see that first of all the odontoid fracture screw trajectory is not compatible and not friendly with the odontoid screw. So the choice of odontoid screw from the start is not ideal for this patient because it is according to Grauer classification, it is type C, where the trajectory of the fracture start from posterior superior to anterior inferior, and this fracture trajectory not amenable for odontoid screw. Number two, we can pick here that there is dislocation, rotatory dislocation in C1, C2, and there is pars fracture as well. So we can say it is not a simple odontoid fracture, it is an odontoid fracture with rotatory subluxation and pars fracture at C2 as well. Next, Mina. Here we can see in the axial cut that C1, C2, there is rotatory instability, and the dents are not centrally located in its place, so there is disruption in the integrity of C1, C2 facets. Next. MRI, we can see the cause of hyperreflexia, the cause of Hoffman and Babinski, which is compression of the cord by the instability which is present, because with this flexion attitude, there is compression by the posterior arch of C1 over the cord. Next. So what is the diagnosis? Next, Mina. We can say it is a fracture dense with C1, C2 rotatory subluxation. We can add there is pars defect, something like Hangman fracture type 1, and the patient complain of devastating neck pain, signs of cord compression. He has previous history of anterior surgery, failed, of course, failed osteosynthesis. So we need to plan, and our plan will focus on how to reduce and how to fix. Of course, we need to intervene anteriorly to remove this screw with the complications that could be anticipated. Either the previous surgeon affects the recurrent laryngeal nerve or not. So examination by NT colleagues are mandatory. Then you will go to do removal of the screw, then to do traction, then to go posterior. Next. This is intraoperative photo after removal of the anterior screw, and we applied tongue traction as well, but we can see that the fracture is not reduced, although with reaching the maximum traction. So we decided to flip the patient to try to do okay, next, to do direct reduction. And we have two options, either to do transarticular Magarel screw or Harms and Gold technique. Next. The Magarel technique is the screw trajectory that fixes C1 and C2. It can be done percutaneously. It can have superior biomechanical configuration, and diffusion service occur through the joints, but it is one screw trajectory. But it is difficult trajectory, unusual for most of the surgeons, unfavorable for this patient because he has dislocation and unable to reduce it with traction, and due to also the presence of high riding vertebral artery, as we can see here in the lower down cuts of the CT and the pars defect. So this patient next is more favorable to do Harms and the Gold technique by applying lateral mass screw in C1 and pars screw in C2. And of course, we'll go down to C3 to augment the construct because of the fracture in the pars at C2. And of course, it is well-known straight trajectories with visual and ductile control. The dorsal fusion can be achieved, and the manipulation of C1, C2 facets, and you can reduce the dislocation is possible, especially in expert hand, and direct repositional could be achieved. The drawback of Gold and Harms approach is that you have sometimes venous plexus that can bleed around the C2 root. Some colleagues may sacrifice the root even. And of course, the two screws trajectory may have some vascular risk. The lateral mass screw at C1, if it is longer screw, can hit the internal carotid anteriorly. The lateral, the C2 pars screw or pedicular screw can affect the vertebral artery as well. Next. So this is what we could achieve for our patient. After removal of the anterior odontoid screw, we went posteriorly. We select to do C1, C2, Harms and Gold, and augmenting the construct by application of C3 lateral mass screw. And we can see here that we could be able to directly reduce the fracture and stabilize the fracture, and we applied bone for fusion. So C1 to 3 fixation and diffusion, and the patient postoperatively has normal motor power, and it was uneventful surgical procedure. Next, so my take-home message from this case scenario that odontoid screw is contraindicated if you have patient with short neck, significant cervical kyphosis, if you have concomitant thoracic kyphosis, because technically demanding and challenging scenario for applying the odontoid screw. It's contraindicated in osteoporotic patients. It is contraindicated when you have comminuted odontoid fracture. It is contraindicated in non-union, as well in C1, C2 rotatory instability, like our case, or unusual fracture trajectory, like our case as well. And the final decision on the approach will be depend on the patient-specific factors and the surgeon experience on different approaches. And I am ready for any questions. Thank you so much.
Thank you so much, my dear Professor Mohamed Fawzy Khattab, for this very interesting presentation. And we are happy to receive questions in the question and answer box. And our dear speakers and our dear professors will answer the question of our dear attendees.